So once more, good morning, dear students. So our topic is about the hard and soft palate and salivary glands. Regarding the oral cavity, we said that oral cavity is divided to two main parts: the oral vestibule, which is bordered by the upper and lower lip and the cheeks, and internally is bordered by the alveolar processes and which is contained the teeth and the gingiva. The main part of the oral cavity is oral cavity proper, which is in the side and in front, is bordered by the alveolar process containing the teeth, and posteriorly or dorsally is isthmus of fauces or isthmus faucium, which is separating the oral cavity from the oropharynx, the oral part of the pharynx. And the roof is our topic, is made by the hard palate in front and the soft palate in the back side. Here is hard and here is soft, and the floor is formed by the very important muscle, which is mylohyoid muscle. We are going to discuss next week about the mylohyoid muscles. The palate not only is making the roof of the oral cavity, but also it's making the floor of the nasal cavity as well. So it's making a roof for the oral cavity, but it's making floor for the nasal cavity. And the palate is divided to the anterior portion, which is bigger portion is hard palate, and it's mainly is osseous or bony part, which is covered by the mucous membrane and periostome, and the posterior part, which is the soft palate, which is mainly it's made by the muscles and dense connective tissue. Regarding the hard palate is formed by the two bones. The first bone is the palatine process of maxilla. As you know, it's these two palatine processes, they are joining together at this median palatine suture or intermaxillary suture in midline. And this is making the anterior three-quarter of the hard palate. And posteriorly is formed by the horizontal plate of the palatine bone, which is making the posterior 1/4 of the hard palate. The oral cavity and the upper alveolar arch is bordering the hard palate anteriorly and laterally, and dorsally the hard palate it continue with the soft palate. As you know, in the hard palate, approximately 8 till 10 millimeter or 1 centimeter behind the central incisor, there is a foramen which is called incisive foramen. And this incisive foramen is the place that which structure is passed by. What structure passed through the incisive foramen? Thank you. And vessels. So nasopalatine nerve and vessels is passing and is supplying, and we are saying that the anterior part of the hard palate. The mucous membrane or the epithel and the mucous membrane in the side of the nasal cavity, it's covered by the respiratory mucosa, and in the side of the oral cavity, it's the special mucosa. It's called masticatory mucosa, which is this mucosa. It's firmly attached to the periostome. So that's why they make the structure which is called mucoperiost or mucoperiostome. And during the application of the local anesthesia to these regions, so it can be very painful. So this is this is why when you are going to dentist and the dentist applying the anesthetic solution in the hard palate, So is one of the painful application of anesthesia, that you feel so much pain because this mucous membrane is firmly attaching to the periostome, and that's why by applying the pressure, so this mucous membrane is stripped out from the periostome, and it's very painful. Regarding the hard palate, so we have some transverse fold with the various number. This is called palatine rugae, this transfer fold, and the function of this it's for the passage of the or guiding of the food toward the pharynx. Another structure that you can see it in the hard palate is in the midline, is this structure which is called palatine raphe, and this is the palatine raphe or the median longitudinal ridge, and here the mucous membrane is firmly attaching to the periostome, so there is almost no submucosal connective tissue, and that's why it's preventing the spread of infection from one side to the other side usually. This median palatine raphe, it's anteriorly or ventrally, it's ending up to this structure, which is immediately behind the central incisor. You can see it. It's called incisive papilla, and which is approximately 4 times 2 millimeter, and it has very important function for the evaluation of the consistency and the temperature of the food. So when you are eating some food, they have very rich innervation here in the incisive papilla, and that's why it's important. They have the important role for the evaluation of the consistency of and the temperature of the food intake. This incisive papilla also is the landmark for when the dentist wants to do the artificial denture or denture. Because it's located exactly in midline, so this is the landmark for setting of the teeth. So we know that this is the center, so we start to set the teeth, central, incisor, lateral, canine, and so on to this area. This incisive papilla also, as we said, it contains a lot of nerve ending. So dentistry, please, when you are doing application of anesthesia to the incisive foramen in this region, please don't apply the needle directly to this incisive papilla. It's very and extremely painful for the patient. So it's under the papilla and posterior to the papilla, you go inside the incisive foramen and canal. More detail about the mucous membrane and about the hard palate. According to the content of the submucosal connective tissue, we divide the hard palate to the 4 zones. Zone number 1, 2, 3, 4. The 1, it's the area that the median palatine raphe is located. And as we said, there is no submucosal connective tissue there, so mucous membrane directly is attaching to the periostome. So that's why they make the mucoperiostome or mucoperiost. Then zone number 2, it's between 1 and 3 that we are going to discuss now. It's an important zone that in anterior side, it contains fatty tissue till the level of canine, and in dorsal part, it contains the mucous palatine glands. In the palate, we have several glands that they are secreting the mucin, and they are the small or the minor salivary glands, the palatine glands in the soft and hard palate. And these glands, they are like a convex shape till the level of the first upper molar they reach. So this is zone number 2, and the very important zone is zone number 3. And this zone number 3 is the place that the palatine sulcus or palatine groove and incisive papilla, they are located. In this area, we have the submucosal, the loose connective tissue, submucosal loose connective tissue, and through this area, through the palatine sulcus, it's passing the greater palatine nerve and vessels, and in incisive papilla, it passed the nasopalatine nerve and vessels. So this is very important, and is the place for the application of the anesthetic solution. Zone number 4, it's called gingiva, so it's gingiva which is firmly again adhered to the periostome of the alveolar process, and that's why they make again the mucoperiost or mucoperiostome. At the region of the palatine raphe in midline, as we said that we have a longitudinal palatine ridge and raphe, which is end up anteriorly to the incisive papilla. And exactly in this area and exactly in the midline, sometimes you can see the overgrowth of the bone. This overgrowth of the bone is called torus palatinus, and usually is not painful. If you touch it and the patient doesn't know about this, and it doesn't make usually problem. The only problem that it's making, and again for dentistry is important, that the older people that they want to wear the denture, so when they put this denture, it's not fit in the maxilla. So that's why surgically you have to remove this torus palatinus. And we have again the same situation also in mandible. They call it torus mandibularis. Also, it's the overgrowth of the bone without any malignancy or without any major problem or pain. Another structure that you can see it in the palate, especially the anterior part of the soft palate and posterior part of the hard palate. These two small opening, which is called fovea palatine or foveae palatine, and here is usually in the posterior end of the hard palate or anterior part of the soft palate usually, and there are two shallow fossa that they are the place of the opening of the mucinous palatine gland. This is the minor salivary gland. And usually the color in this area is orange color. So if you look at the hard palate in this area, it has orange color, which is distinguished with the other mucous membrane of the hard palate. Regarding the neurovasculature of the hard palate, first we start with the innervation. So innervation of the hard palate is made by two important nerve. The anterior 1/3, as we said, nasopalatine nerve, which is coming out of the incisive foramen, and it's a branch of maxillary nerve, which is the second branch of trigeminal nerve, which is passing through which opening of the skull? Foramen rotundum. Then we have the posterior 2/3 of the hard palate is innervated by the greater palatine nerve, which is also a branch of maxillary nerve, and it's supplying the backside, mainly the posterior 2/3 of the hard palate. Regarding the blood supply, the artery blood supply, the main artery of the blood supply of the hard palate is the greater palatine artery. And in some literature, you can also find the nasopalatine artery, or instead of nasopalatine artery, you can find the sphenopalatine artery. Sphenopalatine artery is branch of, or both of them, they are branch of the maxillary artery. The greater palatine artery is arising from the descending palatine artery, and sphenopalatine artery directly from the maxillary artery in the pterygopalatine fossa, and usually is supplying the nasal cavity and the floor of the nasal cavity, which is formed by the hard palate, is supplied by the sphenopalatine artery, which is then through this incisive canal, it gives the nasopalatine artery. Regarding the venous drainage, it's drained mostly most structure in the orofacial region. It's draining to the pterygoid venous plexus. And lymphatic drainage, it's generally the main lymphatic drainage is drained to the submandibular lymph node, but also directly to the superior deep cervical lymph nodes, or very rarely it can drain to the retropharyngeal lymph nodes in the retropharyngeal space that we are going to discuss it next week. Here is the recapitulation of the things that we said it. As you know, here in this region, so we have a greater palatine foramen that it's located in the palatine bone, and here it's coming out the greater palatine nerve and greater palatine artery and sometimes vein. So this is the major blood supply that is arising from the descending palatine artery, which is, as a matter of fact, is located in the pterygopalatine canal or greater palatine canal, which is originated from the pterygopalatine fossa. And the other artery that is less important, it's the nasopalatine artery, that sometimes they write it is a branch of the sphenopalatine artery, which is a branch of maxillary artery. Here in this picture, in addition of this artery, also you can see this whitish dense connective tissue, which is called pterygomandibular raphe, or pterygomandibular ligament, or another name is buccopharyngeal raphe, which is, as a matter of fact, is the border between the buccal region, which is anteriorly is attached to the buccinator muscle, and dorsally is attached to the superior constrictor of the muscle. And this is very important landmark, again, for dentistry, for the administration of the inferior alveolar nerve block at the mandibular foramen in the internal surface of the ramus of the mandible, which is very important landmark how to apply the anesthetic solution in this area. Here you can see this slide, the area that is innervated by innervating the hard palate. So here, this pinkish layer color in the region of the hard palate is the area which is innervated by the nasopalatine nerve. As you see, in this case, whenever you want to do any surgical intervention in the region of the palatine side of the central lateral incisor and canine, so definitely you have to apply anesthesia to the incisive foramen to anesthetize the nasopalatine nerve. The other hand, the posterior two-thirds of the hard palate, which is bluish color, is the area of the territory of innervation of the greater palatine nerve, which is arising from the greater palatine foramen, and it goes anteriorly to the zone number 3, which is the palatine sulcus or groove, and usually the nerve is medially, the artery is laterally, and it's innervating this area from the first premolar till the last molar. The posterior part, which is green, it's the area of the innervation of the soft palate that we are going to discuss, and specifically is the lesser palatine nerve that we are going to discuss. Be careful. What we said here, nasopalatine nerve, greater palatine nerve, and the lesser palatine nerve, they are all in the palatine side, yes? So it's not enough that if you apply anesthesia here or here, because the vestibular side still it's working and they have their sensitive innervation. In addition of this palatine side, you have to also apply anesthesia to the nerve which is responsible for innervation of the vestibular side. For example, the superior labial branch of the infraorbital nerve, supplying the anterior area. The anterior and medial superior alveolar branches, which is supplying is branch of the infraorbital nerve, also is supplying the anterior and the central incisor, canine, and premolar, and the posterior superior alveolar branch, which is innervating, which is coming from the or passing through the maxillary tuberosity and is innervating the molar region in the vestibular side together with the long buccal nerve, which is supplying the cheek region. So those are all the nerves that you can see, and the area determined by the color, so which is innervating this region, and it's very important for the applied, the clinical applied and clinical application of the anesthesia. Here is the application of the anesthesia to the incisive foramen. It's very painful. Be careful. You see that the needle, it doesn't go directly to the incisive papilla, and it's going under that and below that, and it's reaching to the incisive foramen. And this is the area of the innervation and numbness, which is the central incisor till canine, only in the palatine side. On the other hand, is the area of the application of the anesthesia to the greater palatine nerve, or the greater palatine nerve block, which is passing through the palatine groove or sulcus, and those are the area that is innervated by this nerve. It means that the molar region till the first premolar, it can be numbed via the application of the block anesthesia of the greater palatine nerve. Regarding the venous and lymphatic drainage, as we said, the venous drainage, it's draining to directly to the pterygoid venous plexus. This pterygoid venous plexus is very important plexus. Most of the orofacial region, they are drained to this plexus, and is located in the infratemporal fossa. It's very important deep region in the head region that next week we are going to discuss about the infratemporal and pterygopalatine fossa. It's a very important vein which can be transmitted and connected via the emissary vein, mainly through the oval foramen to the intracranial base, which is a cavernous sinus, and is make the brain abscess for the spread of infection or spread of the metastatic cells. Is important. Another important that previously I told you, for application of the block anesthesia to the maxillary tuberosity for the numbness of the posterior superior alveolar nerve. So you have to be careful of this plexus, because if you wrong application, do it instead of tuber maxilla, the needle, it goes more toward the pterygoid venous plexus. You inject and you wait that it will be numbness, but in 30 seconds you can see the patient has a swallowing of the face, which is the sign of the bleeding from the pterygoid venous plexus. If it happened to your clinic, so immediately the ice compression from outside and inside, you have to do it. The lymphatic drainage, as we said, that mainly to the submandibular lymph node, is a group of lymph node in the submandibular region under the mandible, and or directly it can go to the superior deep cervical lymph nodes. Usually the deep cervical lymph node, you can find it parallel with the wall of the internal jugular vein. So this is very important. If the doctor wants to remove the metastatic cells from the lymph node that they are affected by these cells, so he has to find, or she has to find the internal jugular vein, and parallel with the internal jugular vein, those are the deep cervical lymph nodes, which are divided to the superior and inferior. And we said that all less commonly to the retropharyngeal lymph node, which is the lymph node here in some slide. In next slide I will show you. Next one is soft palate. Yes, soft palate also is a very clinically important region for the examination of the oral cavity by doctor. And you can see, as a matter of fact, the soft palate is the continuation of the dorsal continuation of the hard palate, it is. And in the center of the soft palate, you can see a tear-shaped structure, which is called uvula, and it's located exactly hanging in the center. Then the place that it's connecting the oral cavity proper to the oral part of the pharynx is called which is called oropharynx. So it's called this opening, which is called isthmus of Faucium or pharyngeal isthmus, which is the place for the connection of the oral cavity to the oropharynx. And finally, near to the soft palate, between the two arches that we are going to discuss, is the place for the location of the palatine tonsile, which is the structure that it's examined by the oral examination of by the doctor. So a soft palate, we said that as a matter of fact is the dorsal continuation of the hard palate, and it's acting like a valve. So either this soft palate, it goes down, and in this case there is closing the oropharyngeal isthmus. It means that narrowing or the closing of the oral cavity and the oropharynx, and or elevating the soft palate up there and separating the nasal part of the pharynx from the oral part of the pharynx. So this is the two important functions that the muscles of the soft palate, they are doing it, and we have 5 paired muscle in the soft palate. One of them, it's in the center, which is, as a matter of fact, be careful, it looks like one, but it's, as a matter of fact, is a paired muscle of the left and right ovula, yes? So don't do mistake. So ovula, it contains of paired muscle, left and right, but it looks like a tear shape hanging in the midline. And we are going to discuss one by one. So the basic structure of the soft palate, that all of the muscles of the soft palate, they are attaching to that, this dense connective tissue, and this is the basic structure of the soft palate, which is called the palatine aponeurosis. This palatine aponeurosis is a dense connective tissue which is all this muscle is attaching and is making the base for the soft palate. And that's why the soft palate, it's a musculature or muscular structure together with the dense connective tissue, which is aponeurosis, the palatine aponeurosis. Some muscles like a palatoglossus and palatopharyngeal, they are restricts the communication between oral cavity and oral pharynx, that we said it and we are going to say. The tensor veli palatini, for example, it's a muscle also not only is acting on the soft palate, but is acting also to the auditory tube. Auditory tube, which is near to the carotid canal, it passing to the musculotubar canal, which is subdivided to the semi-canal for the tensor tympani muscle for upper region, and semi-canal for the auditory tube or eustachian tube or pharyngotympanic tube. So it's acting in this auditory tube, which is opening this pharyngotympanic or the eustachian tube. This 5 muscle, from this 5 muscle in each side, we have one muscle that it was, or 2 muscles that they are in the midline, they make the ovula. 2 of them, like a tensor veli palatini and levator veli palatini, they are originated from the base of the skull, and they are going down, it means descending into the palatine aponeurosis. And the other 2, which is palatoglossus and palatopharyngeus, they are ascending, it means from the tongue and pharynx, they are ascending to the palatine aponeurosis respectively, the palatoglossus from the tongue and palatopharyngeus from the pharynx, and the ovula, we said it. So this is a table except the palatopharyngeus muscle that is showing you the name of the muscles of the soft palate. About the palatopharyngeal muscle we are going to discuss also. Those are the origin, those are the insertion, and here is the innervation and the function. As you see, the tensor veli palatini, levator veli palatini, and ovular muscle, or musculus ovule, these three muscles, they have a function as a separating the nasopharynx from the oropharynx. Separating nasopharynx from the oropharynx. So they have this common function, which is mainly the levator veli palatini, mainly they are acting during the swallowing or phonation. So when you are eating the food and you are swallow, so they are elevating the soft palate, and in this case, you are closing the communication of the nasal cavity with the nasopharynx. So that's why they are preventing the food to jump it to the nasal cavity. So, and this is very important role for the swallowing and directing the food toward the pharynx, oropharynx, and down toward the esophagus. Yes. So this is the one important things that we can see at first sight in this table. And palatoglossus, and additionally the palatopharyngeus muscle, those are the other two muscles that they are narrowing the oropharyngeal isthmus or the isthmus of Faucium by the separating of the oral cavity from the oropharynx. So those are the narrowing of the isthmus of Faucium, these two muscles. We are going to discuss the details of each muscle. Another important things that first sight that you can see and is very important is the innervation. As you see, the innervation of all muscles of the soft palate, including the palatopharyngeus muscle, is innervated by the pharyngeal branch of the vagus nerve, which is together with the glossopharyngeal nerve, which is cranial nerve number 9, is making a pharyngeal plexus. Yes? So if you say pharyngeal plexus, it means that you are talking about the cranial nerve number 9 and 10 together. Yes? In some literature, you can see vagus nerve only, pharyngeal branch of it. In other literature, you can see only glossopharyngeal nerve. Yes? So according to me, the best one is to say the pharyngeal plexus, which is 9 and 10, and in this case, you are done. The only exception that is not innervated by this pharyngeal plexus is tensor veli palatini. As you see, it has absolutely other source of innervation, which is the V3, is the third branch of the trigeminal nerve, which is mandibular nerve, and respectively, mainly nerve to the medial pterygoid muscle, which is the branch of mandibular nerve, is innervating the tensor veli palatini. So this is another important things that you can see this from this picture. And here are the origin of the and insertion of this muscle that one by one we are going to discuss. The first muscle, the tensor veli palatini, which is located here, as you see. It has two parts, if you see. It has the vertical part, this muscle, which is the muscular part, that is going from the base of the skull, respectively from the spine of the sphenoid bone or angular spine. It going downward till it reached to this hook-shaped structure of the pterygoid process, which is called pterygoid humulus. And the tendon is turning around this humulus, and it's continue horizontally. And as you see, the continuation of the horizontally of the tensor veli palatini is making a dense connective tissue, which is making a base for the soft palate for attachment of all other muscle. And this one is called palatine aponeurosis. So the recapitulation is that the tensor veli palatini, it has a vertical muscular part, which is going from the spine of the sphenoid bone, and is going downward and is passing lateral to the membranous part of the eustachian tube. That's why it's explaining how it affecting to the opening of the eustachian tube. Yes, and it's going downward, and the horizontal portion of this muscle, it's becoming more connective tissue, which is making the palatine aponeurosis, which is the which is the basement or basic structure for the soft palate. So this connection of the laterally continuation of this muscle to the membranous part of the pharyngotympanic tube, be careful, or eustachian tube or the auditory tube, it's important role for the affecting of this muscle, not only for the soft palate, but also for opening of the eustachian tube. So regarding this palatine aponeurosis that I said it, this palatine is anteriorly is attaching to the posterior aspect of the hard palate, and posteriorly this palatine aponeurosis doesn't attach to anything, and in this case is free, and it's continue, as a matter of fact, as a basement for ovula, yes, as you see here. And tensor veli palatini, the function, according to name, tensor, it means that it tenses. It tenses or making firm the soft palate. In this case, it's allowing that the other muscle that they are attaching to this palatine aponeurosis can more effectively acting to this region. So as we said, by tensing of this soft palate, in this case, they are separating the hypopharynx and nasopharynx, or oropharynx and nasopharynx, mainly during the swallowing. And also an additional function is the opening of the pharyngotympanic tube or the auditory or the eustachian tube, especially when you are yawing or swallowing. So when you are sitting in the airplane and you have some pressure in your ear, in middle ear, is usually they recommend you to chew the chewing gum, or you do yawing, so then you are adjusting the pressure between outside atmosphere and inside the inner ear, and it's releasing or decreasing the pain. And this is the function of this tensor veli palatini, which is opening this eustachian tube, which is connecting the nasopharynx to the middle ear or the tympanic cavity and adjusting the pressure between these two sides. And as we said, the innervation of this muscle is made by the medial pterygoid nerve, or nerve to the medial pterygoid muscle, which is branch of the mandibular nerve exceptionally. Another very important muscle of the pharynx is this muscle, which is called levator veli palatini. And this levator veli palatini is originated from the petrosal part of the temporal bone, or petrosal bone, or pyramid of the temporal bone. And it's directing and descending caudally to the upper surface. As you see, here is the aponeurosis, and here is the upper surface of the palatine aponeurosis. And then it continues to the other lamella, and then it's also, it has adjacent and medial to the pharyngotympanic tube or the eustachian tube. So that's why in some literature also you can see that the levator veli palatini also is affecting to the eustachian tube or pharyngotympanic tube. There is always discussion that which muscle is doing what, but according to the new literature, the tensor tympani is open as a dilatator or dilatator of the eustachian tube, and levator veli palatini is closing as a closure of the eustachian tube. But anyway, so this muscle, the function, it's elevating the muscle. So as a matter of fact, it's the only muscle that it's mainly elevating the soft palate according to its name. Yes, tensor, tensing, levator is elevating the soft palate from its neutral position. And in this case, they close the pharyngeal isthmus between the nasopharynx and oropharynx, and innervation, as we said, is by the pharyngeal plexus, which is here, I wrote it, the 9 and 10, but mainly is the pharyngeal branch of the vagus nerve, which is cranial nerve number 10. And that's why for examination of the patient, so you have experience if you go to the doctor and wants to check up, so he will ask you to say, ah, yes. So this is important information for the doctor, that he can look at this region. You look at not only the soft palate, you can look at the palatine tonsil, you can look at the oropharynx, you can look at the position of the ovula, yes? And as you know and as you saw, that the ovula is located in the midline exactly, in the normal circumstance. So normally when you say this ovula is hanging in the midline, and the palate is elevates evenly in the midline. So in both sides are acting equivalent, and the ovula is going up there in the midline. But what will happen, that one of the muscle or one side, it will be paralyzed, either by the affecting of the palsy of the nerve, number 9 or 10, or it can be also due to the infection of abscess or tumor, a mass that is pushing the ovula to the other side, yes? And you can be the first doctor that you can recognize something is wrong for the patient, yes? It must not be a neurological problem or affecting of the nerve palsy, but it can be a tumor. That tumor is in the deep region and you don't see it, yes? If it is in the skin or in the tongue, or the somewhere that is visible, so the patient will recognize it, yes? But patient doesn't know that something is growing here in this area, which is called parapharyngeal space, or the lateral pharyngeal space. And this is growing, and suddenly you see that the ovula, instead of is hanging in the midline, is deviated to the other part. So something is pushing it, yes? It's enough to send it to the CT scan or MRI, and you see, wow, yes? And this is very important for the early diagnosis, yes? And if you on time, you catch up this diagnosis, so treatment is much more easier than you wait and this tumor is spreading to the lymph node and other part of the body, yes? So that's why this learning of anatomy for you, it has the clinical importance for you, for your future work, yes? It's not just a name for you that this one is passing, this one is this one, and then you pass the exam and bye-bye, yes? So those are all the information that one day you can face it, yes? You can in whole your life, you don't face it, but first patient, your patient after you get your degree, it will be this one also, yes? So that's why, as much as you know this anatomical structure and the physiological structure, so you can see. So for example, this patient, it has the nerve palsy of the cranial nerve number 9 in the left side. So in this case, or can be number 10, or pharyngeal plexus. So in this case, the left soft muscle, left side of the soft palate, it doesn't work. So what will happen? The left side is paralyzed, but the right side is working normally. So when the patient say, so the right side that is working normally is taking it up, but left side is paralyzed, it cannot. So that's why the deviation of the ovula is going to the normal side, yes? Not to the paralyzed side, but it's deviated to the normal side, which has here in this picture, the right side. The palatopharyngeus, or the palatopharyngeal muscle, it's considered also as a muscle of the soft palate, and also we consider it as a muscles of the pharynx also, that we are going to discuss. This muscle is coming from the superior surface of the palatine aponeurosis. So here, as you see, is the superior surface of the palatine aponeurosis, and then from each side, it's going suddenly vertically down, or caudally, as a longitudinal muscles of the pharyngeal wall. So as you see, it's making the muscles of the pharynx, and also it's making the muscles of the soft palate, and anteriorly, it reached to the posterior margin of the hard palate. This muscle, palatopharyngeus muscle, has two functions. One function for the soft palate, which is depression. So it's depressing the soft palate, and in this case, the moving the palatopharyngeal arches toward the midline is like a curtain. So you take the curtain and close it. and you take a curtain and you open it, yes? So this is very important, that to closing of the oropharyngeal isthmus, and this is action for the soft palate, but it has an action for the pharynx because it's a muscle of the pharynx as well, and this is elevating the pharynx upward as well. The innervation pharyngeal plexus 9-10 cranial nerve that we said, and here is the very nice example that how it's working. This is the isthmus of Faucium. This is the connection of the oral cavity with the hypopharynx or the oropharynx, and the action of the palatogluteus and palatopharyngeus. You see that we have two arches in the palate. One is located posteriorly and medially, and the other is located anteriorly and laterally. The anterior and lateral is the palatogluteal arch, which is under that is palatogluteal muscle. And this one, which is dorsally and medially, is the palatopharyngeal arch, which is under that is palatopharyngeal muscle. And between these two arches, there is a palatine tonsil. Yes? So be careful, the palatine tonsil is located between the palatogluteal arch and palatopharyngeal arch. And the function of these two muscles or two arch is that you are closing like a curtain by the contraction toward the medially and is narrowing the isthmus Faucium. It means narrowing the communication between oral cavity to the oropharynx, and this is very important. And clinically is very important also. When you look at this area, you have to see if this palatine arches, they are inclined, so they have convexity on it, it's painful, it's redness on it, is the sign of inflammation or not. So those are these are the sign and symptom that it give it to the doctor to prescribe you, for example, some anti-inflammatory drug medication or some antibiotic medication in the case of the, for example, infection of palatine tonsil, for example. Yes, and finally, this palatogluteus muscle, which is, we said that palatopharyngeus muscle was the muscle of the soft palate and muscles of the pharynx, and palatogluteus is the muscles of the soft palate and muscles of the tongue for the stomatologist. So, and this muscle is originated from the inferior or surface and the posterior surface of the margin of the aponeurosis, and is attaching to the lateral surface of the dorsum, lateral surface of the root of the tongue. So here is the lateral surface of the root of the tongue, which is next week we are going to discuss about the tongue, and is attaching to the inferior surface of the palatine aponeurosis, and it's making the lateral and anterior arch, as we said, in this region, this arch, and it's making a palatogluteal arch, and lateral to anterior to the palatopharyngeal arch is located. The function, you compare it with the palatopharyngeus. Palatopharyngeus was that depressing the palate and elevating the pharynx. Here, palatogluteus is depressing the palate, the same, but elevating the back of the tongue because it's the muscles of the tongue also. In this case, it's closing the oropharyngeal isthmus, innervation pharyngeal plexus, cranial nerve number 10 and 11. And finally, the ovula or ovular muscles, there are double muscle left and right, that it's originated from the posterior nasal spine. Is belong to which bone? Palatine bone, thank you. And is attaching to the palatine aponeurosis in the dorsal aspect of the palatine aponeurosis. And also the function is elevating and retracting of the ovular structure. So in this case, again, like a tensor veli palatini, levator veli palatini, is closing the pharyngeal isthmus between the nasopharynx and oropharynx, and is innervated by the pharyngeal plexus. Regarding the artery blood supply of the soft palate, this artery blood supply, We have three main sources of this artery blood supply. One is lesser palatine artery, which is, as a matter of fact, like a greater palatine artery, is a branch of the descending palatine artery, which is itself is a branch of maxillary artery, which is itself branch of external carotid artery, that in cardiovascular system we are going to discuss. Another artery is this two artery that they are supplying the soft palate. It's the ascending palatine artery, which is a branch of fascial artery. It's very important artery also for blood supply of the palatine tonsil. They have this ascending palatine artery. It has a tonsillar branch, which is the main source for the blood supply of the palatine tonsil. And that's why it has clinical importance that during the tonsillectomy, sometimes you have heard that some child or some person that the doctor must remove this tonsil. He says. So this tonsillectomy is a simple operation, yes, but it can be dangerous, that it can be fatal, because if the doctor is cut this tonsillar branch of the palatine, ascending palatine artery, the bleeding can kill the person, or it can be fatal consequence for that. The last artery that is supplying the soft palate is the palatine branch of ascending pharyngeal artery. So all this artery that we mentioned, descending palatine artery, branch of maxillary artery, branch of external carotid artery. Pharyngeal, palatine branch of the ascending pharyngeal artery, which is medial branch of external carotid artery. Ascending palatine artery, which is branch of fascial artery, it's a branch of external carotid artery. So external carotid artery is the crucial, important artery for the orofacial region that we are going to discuss it. And this is the details of the what I'm saying now. Is, for example, this is the fascial artery, that it's the ventral branch of the external carotid artery here. Here's the common carotid artery, which is divided to the internal and external. And this external, it has three ventral branches, the superior thyroid, the lingual, and the fascial. So here is the fascial. And in the neck region, the fascial artery giving one artery, which is ascending palatine artery. And this ascending palatine artery in the outermost of the pharynx, layer of the pharynx, it's going and it's passing through the superior border of the constrictor muscle of the superior constrictor muscle of the pharynx. It's going to the soft palate and is innervating it. So this is one. Second artery is ascending pharyngeal artery, is the direct medial branch of the external carotid artery. It has the same pathway which is going to the outermost of the wall of the pharynx, superior aspect of the superior constrictor muscle of the pharynx, and it reaches to the soft palate. And finally, the descending palatine artery, in some literature, instead of descending palatine artery, they write it directly greater palatine artery. So it's passing through the greater palatine canal or pterygopalatine canal in the pterygopalatine fossa, is going down, and in this area is divided to the greater palatine for the hard palate and lesser palatine for the soft palate. So these three main arteries, main artery for blood supply of the soft palate. And as we mentioned it, more or less the venous drainage is the same as artery. So if we have lesser palatine artery, we have lesser palatine vein, but there are very small veins that finally they are draining to this venous plexus that we mentioned. Is the venous plexus, pterygoid venous plexus, which is communicating to the cavernous sinus through the foramen ovale, for example. And it's important, and it's equivalence of the branches of the maxillary artery, but we don't have it for the vein, but for vein we have the pterygoid venous plexus, which is located in infratemporal fossa, and as you see is located between the medial pterygoid muscle and the lateral pterygoid muscle, is located in infratemporal fossa. Another source of the drainage, or the place for the drainage of the soft palate or palate, is pharyngeal plexus. The pharyngeal plexus in the dorsal wall of the pharynx. They make the plexus that some of the soft palate, they can directly goes there, or it can directly, it's draining to the fascial vein, that it's more or less the same course we have it with the fascial artery, but there is a difference in the neck region that the artery is going much more deeper than the vein in the fascial region. So 3 sources of the venous drainage: the pterygoid venous plexus, pharyngeal plexus, and the fascial vein. Lymphatic drainage that we already said, mainly submandibular lymph node, which is here, and retropharyngeal lymph node in the retropharyngeal space. Next week we are going to discuss. And parallel with the internal jugular vein is the superior deep cervical lymph node, and here is the inferior deep cervical lymph node. Generally, they call it deep cervical lymph node, and they are located parallel with the internal jugular vein. The innervation of the palate that we already mentioned, those nerves that we mentioned it, and it's innervating the palate, the greater palatine nerve, the lesser palatine nerve, the nasopalatine nerve. Those nerves, they contain the general sensory fiber. It means that those are the nerves that they carry the sensory fiber. For example, if you touch the palate, you feel it. It's a sensitive innervation. If there is inflammation, or if somebody put the needle there, you have a pain. So it's a sensitive innervation, yes. Those are the pain, touch, pressure, those are the general, yes. So then, and those are greater palatine, lesser palatine, we already discussed it. So the greater palatine nerve, the area of the hard palate till first premolar, the nasopalatine nerve, area of the hard palate for the incisive and incisors and canine, and the lesser palatine nerve for the soft palate, yes? But we have parasympathetic innervation or autonomic innervation, which is for the secretion of the glands, yes? Secretion of the glands is out of your control. So you don't think that, okay, now I secrete some glands, yes? So that's why they call it autonomic. It's autonomic, yes? It's not under your control. And this autonomic innervation is divided to the parasympathetic and sympathetic. Parasympathetic, remember, it's producing a stimulating the secretion, yes? So remember always the parasympathetic, it's working mostly when you are resting or digesting. You are relaxed, and the digestive enzyme and secretion is secreting, the salivary gland is secreting, and you are relaxing and resting, yes? Sympathetic, it's fight and flight. So stress. For example, next week, Wednesday, when you see the test, is not that much difficult. But if you are stressed, so what will happen? You see your mouth is dry. Yes? This is a symptom of sympathetic. My mouth is not dry because I'm stressed, because I'm talking, so I drink a little water. So this is the remembering for that, yes? So sympathetic, fight and flight. The parasympathetic, rest and digest, yeah? So the parasympathetic innervation of the glands that you have it in the hard palate, in the soft palate, it's via a branch of fascial nerve, which is originated from the pterygopalatine fossa that we are going to discuss it. It's the greater petrosal nerve at greater petrosal hiatus and canalid pass, if you remember. And the sympathetic source is coming from the T1 segment of the spinal cord that we are going to discuss it in the chapter of the nervous system. That it's arising as a nerve like a deep petrosal nerve, and they join with the greater petrosal nerve, and they make the nerves of the pterygoid canal or Vidian canal. So as you see here, the fascial nerve that we said that we have anterolateral section, posterolateral section, and descending section. Between the anterolateral and the posterolateral is the genu or geniculum, and here is the area that it's giving the greater petrosal nerve, which is joining with the sympathetic nerve, which is called deep petrosal nerve, and is arising from the T1 segment of the spinal cord. They join together and they make the nerve of the pterygoid canal, which is Vidian canal, and they go to the pterygopalatine ganglion, which is parasympathetic ganglion, and there it's going to the greater petrosal nerve, lesser petrosal nerve, and now this fiber, which is the parasympathetic and post-sympathetic fiber, the post-sympathetic fiber, it can affect the gland and is start to secrete these glands. Yes? So this is the recapitulation for the innervation of the sensation and the secretomotor innervation of the parotid of the glands. So salivary gland is the next chapter and last chapter of our lecture. Before we start about the salivary gland, you know that the saliva, it's a very important, it has a very important function that is making the oral mucosa moist. So it has a digestive and protective function. For example, in saliva, there is an enzyme which is called amylase, and this amylase, it's in the oral cavity, is starting to do the digestive and the splitting of the starch in your food. Or in saliva, for example, there is a lysozymes enzyme which has a bactericide effect. Yes, so it can kill some microbe or bacteria that you can take it by the food to your oral cavity, and it can kill it. Do you know how much saliva is produced by every day? It's variable, but between, yes? 1 and 2? Yes, half a liter till 2 liter is the wide variation that every day you can produce the saliva, of course, as much as you drink more water, so it's better not to be dehydrated. The salivary glands they are classified as a 3 type according to their secretion. The serose secretion, which is a watery secretion. They contain the alpha amylase or petialin for the breaking down of the starch to the maltose and glucose. Mucose or mucinose, they are producing the protein which is called mucin and is usually helpful for lubrication. When you are eating the food, this saliva, it contains mucin secretion, and they are bonding with the food, and it's easier for the swallowing, yes, that if it is dry, so it's difficult to swallow. And most of the salivary gland, they are seromucinose or seromucose or seromucinose. They are mixed. As we mentioned it again and again, parasympathetic stimulation is via the acetylcholine, which is the neurotransmitter for the parasympathetic, is act to the muscarinic receptor of the gland and is increasing the salivation. Parasympathetic, increasing. And sympathetic stimulation, fight and flight, so it's decreasing the salivation. The salivary gland, we divide them to two main types, the major salivary gland and the minor salivary gland. The major salivary gland, there are 3 paired gland, the parotid gland, which is the biggest, the submandibular and sublingual gland, all these major salivary glands, they are enclosed by the fibrous capsule. These are the characteristic of the major salivary gland. And usually they have excretory ducts. So they have a duct that they are finally open to the oral cavity, and the normal production of the saliva is 0.5 till 2 liter per day. The first salivary gland and the largest one is the parotid gland. And this parotid gland, it's located variable size. So usually it's coming from the zygomatic arch. It's like a wedge shape or triangular shape, which has a base in the upper part and apex in the lower part that we are going to discuss. Very important, never forget, inside the parotid gland, it passes facial nerve. Facial nerve splits the parotid gland into the superficial and deep lobes. So the border between superficial lobe and deep lobe of the parotid gland is facial nerve. Facial nerve is coming out of the skull through is coming out of the skull through. Thank you. You saved me from the infarct. So stylomastoid foramen, yes, is entering to the skull through the internal acoustic meatus together with 8 and labyrintral vessel. Thank you. So this is the facial nerve. It has a very clinical importance, and I will tell you in a while. So from the deep part of the gland or deep lobe of the gland is arising the parotid duct. During the pathway of the parotid duct, you can find in sometimes when you are dissecting next semester in the dissection room, the parotid gland, you can see an accessory parotid gland. Usually it's parallel with the pathway of the duct, which is going over the masseter muscle, very important. It's turning and is piercing the buccinator muscle and is open to the oral vestibule. Be careful, not oral cavity proper, but it's open to the oral vestibule, to the opposite to the second upper molar in the place which is called parotid papilla. So if you look at your cheek region in the oral vestibule, opposite to the upper second molar, you see an elevation of the mucous membrane, which is called parotid papilla, and if you press it, so you see that the saliva is coming out, and this is the orifice of the opening of the parotid duct or Stenson's duct. Important and funny is that the parotid gland is the largest major salivary gland, but it's just producing 20% of the total saliva that in oral cavity is produced. The main production of the saliva is via the submandibular gland that we are going to discuss. So the position and location of the parotid gland, as we said, it's the wedge shape. The posterior part, the superficial part, is going over the half of the way of the masseter muscle. Posteriorly is wedging behind the ramus of the mandible and is going inside toward the medial pterygoid muscle. Posterior aspect is going to the anterior aspect of the sternocleidomastoid muscle, and the apex is going reach to the posterior belly of the digastric muscle. So this is the location, and as we said that the facial nerve is dividing the parotid gland to the superficial and deep, and this parotid gland, it's enclosed by the fascia, which is called parotidomasseteric fascia. In the next slide I'm going to talk, is a layer from the investing layer of the deep cervical fascia. And the passage of the parotid duct, we said that it's going over the masseter muscle, is turning and is piercing the buccinator muscle and is opening to the oral vestibule opposite to the second upper molar teeth. And the secretion of the parotid gland is pure serous secretion. The parotid gland is pure serous secretion, so it means that it has watery saliva and it contains of amylase for the splitting of the starch, and it's important for the food bolus formation for the oral digestion. To approximately to guess how the parotid duct is passing, for example, when you are dissecting the dead body or cadaver, so if you do the line which is connecting the tragus of the external ear to the small shallow fossa that you have it in the upper lip in the center, so it's called philtrum. So this line is the line that is showing you the passage of the parotid duct. Another line that we can use is in the lower part of the auricle, which is connecting to the nasal wing or the wing of the nose. So this is another line. And you can see always, not always, sometimes through the pathway of the parotid duct, you can find the accessory parotid gland as well. This is what I was talking about. This is parotidomasseteric fascia, which is not only covering the parotid gland, but also it's covering the surface of the masseter muscle. So that's why this fascia is called parotidomasseteric fascia. This is the fascia that is coming caudally as an investing cervical fascia. It's important. This fascia is superiorly or cranially is attaching to the zygomatic arch, and inferiorly it's going, or caudally it's going to the margin of the mandible, body of the mandible, and is continue as an investment or investing layer of the cervical fascia. Dorsally, this fascia is turning the ramus of the mandible behind, and it's separating the medial pterygoid muscle, which is attaching to the inner surface of the angle of the mandible from the parotid gland. And at the region of the angle of the mandible, we have this fascia very thick, and it's the thickest part of this fascia, which is called angular tract. And this angular tract is separating the parotid gland from the submandibular gland. And it's clinically important that infection from parotid gland, it cannot goes to the submandibular gland. So this is called angular tract because at the mandibular angle is located the thickness of this fascia or this. Important relationship of this parotid gland, be careful, three structures they are passing through the parotid gland. Very important. One we already said is fascial nerve, which is after coming out of the skull through the stylomastoid foramen, after giving some branches, it enters to the parotid gland and is making a plexus, which is called parotid plexus or intraparotid plexus, and it giving 5 branches. To remember these 5 branches, if you put your hand in the fascial region, so those are the temporal, zygomatic, buccal, marginal mandibular, and cervical branches. In the next slide, I'm going to show you. And those are the branches of the fascial nerve that it's important for innervation of the mimic muscle or facial muscles of the facial expression. So be careful, the masticatory muscle that we were discussing is innervated by mandibular nerve, thank you. Mimic muscle or the muscles of the facial expression is innervated by fascial nerve. And those are all these 5 branches that you can see. Another structure that you can see it in superficial to the parotid gland it passes is retromandibular vein. And this retromandibular vein is formed by the junction of the superficial temporal vein and maxillary vein. And usually after it's coming down from the mandible, it's divided to the anterior and posterior division or branches. The posterior one is attaching or is draining to the external jugular vein, and the anterior vein, one is draining to the fascia. So here it's important. And then the deepest layer is the external carotid artery. External carotid artery enters to the parotid gland. Inside the parotid gland, it gives posterior auricular, and also two terminal branches, the maxillary and the maxillary, which is deep, is behind the neck of the mandible, it passing, and the superficial temporal artery, which is approximately, if you want to find the superficial temporal artery, 1 centimeter in front of the external acoustic meatus. So here you can see or feel the pulsation of the superficial temporal artery. Here, they are passing through the parotid gland. So the relationship of the parotid gland tree structure, the most superficially retromandibular vein, then fascial nerve, then the deepest structure, external carotid artery. So here I have the schema that you have the wedge-shaped parotid gland, and if I remove the superficial part of the parotid gland, the first thing that I see is retromandibular vein, which is coming from the superficial temporal vein and the maxillary vein, and is making the posterior division and anterior division. Here is better picture that you can see the superficial temporal vein. Here is maxillary vein. They form the retromandibular vein, and is divided to the posterior division, which is draining to the external jugular vein, and anterior division, which is draining to the fascial vein, which is draining to the internal jugular vein in cardiovascular system we are going to discuss. Next step, if I remove the vein, behind or deep to the vein is fascial vein, fascial nerve. And this fascial nerve, as we said, it's dividing the parotid gland to the superficial and deep, and is going as an intraparotid plexus to the 5 branches that is innervating all this mimic muscle by this fascial nerve. And as we said it, if you want to remember the branches of the fascial nerve, you put your hand on this region, and here is the temporal, zygomatic, buccal, marginal mandibular, and cervical branches of the fascial nerve from the parotid or intraparotid plexus. And finally, if I remove the nerve, then the deepest layer that we say is the external carotid artery, which is inside the parotid gland. It's giving the branch posterior auricular, which is not present, the superficial temporal, which is giving the transverse fascial inside the parotid gland, and also the maxillary artery. All this division, they are made inside the parotid gland. And here is the better picture for the external carotid artery after the removing of the parotid gland. So the posterior auricular, the superficial temporal with the transverse fascial, and this maxillary artery, as you see, behind the neck of the mandible is going to the infratemporal fossa and the pterygopalatine fossa that next week we are going to discuss. Very important region of the head, the pterygopalatine and infratemporal fossa. And very nice cross-section of the parotid gland, of the parotidomasseteric region. You see here is the parotid gland. Here is the ramus of the mandible or angle of the mandible, which is masseter muscle is attaching and medial pterygoid muscle is attaching here. And from the gland, it's passing the parotid duct, which is going over the masseter muscle, superficially piercing the buccinator muscle, and is open to the opposite to the upper second molar in the vestibular oris. And in here, this cross-section, you can see superficially retromandibular vein, the fascial nerve, and the external carotid artery with the sympathetic plexus that you can see it very nice in this picture. Clinical aspect, sorry, the salivary gland usually that is a target of the tumor in orofacial region, but thanks God that is usually there are benign tumor. And why I said that is important, because benign tumor usually is located in superficial lobe, yes? And this is good for patient because you can remove the tumor with the superficial lobe and facial nerve is intact. That's why I said that the facial nerve is the border between superficial and deep lobe, yes? But if it is malignant tumor is penetrating to the tissue. Is going invasive, is destroying the tissue, and then unfortunately if you want to remove this tumor, you have to remove a big amount of the gland, and you have to inform the patient that he lose or she lose the innervation of the mimic muscle of the face, because his life or her life is much more important than the paralyzing of this thing. So that is the clinical aspect, that why you have to know where is the facial nerve, the border between superficial and inferior. And another clinical important is that sometimes you can find the cyalolith or stones inside the salivary gland. And have you heard about the mumps? Mumps is the viral infection that usually is affecting the parotid gland and is very painful. And in a while I will tell you why it's very painful. And the lymph node of the parotid gland is draining to the superficial and deep cervical lymph node. Here, for example, is during the surgery, you cut the branches of facial nerve. This is 1 and 2nd, yes? If you see 2 ends, you can immediately call neurosurgeon that thanks to the microscope, now his technology is so much well, so he can come and suture this nerve together. So the prognosis, it's somehow you can return back the innervation of the mimic muscle or muscles of the facial expression. So because it's affecting the appearance of the people. So whole life, if the patient will be like this, so it's psychologically is affecting and functionally is affecting. So it's better as much as possible to save this facial nerve. And also is a place for the origin of the abscess here in the CT scan, or here in the CT scan, the region of the parotid gland, or mumps that I said that is usually is affecting the children, the edema of the parotid gland, and this enlargement of the parotid gland is pressing the capsule, the fibrous capsule, and this fibrous capsule doesn't allow the parotid gland to expand, and that's why you have a pain. This is one reason. And second reason is, be careful, the parotid gland, the deep part, is located between 2 bony structures, mastoid process and posterior part of the ramus of the mandible, yes? And those people that they got these mumps, if somebody get? No? So they explain that they have pain when they talk or they open the jaw. So when you open the jaw, depression, the ramus of the mandible go back, pressing the gland between mastoid process, and is painful. Yes, this is explaining the pain. And here is the abscess in the gland. And if you see the papilla, the parotid papilla opposite to the upper second molar in the cheek region, and you press, if you know exactly where it's open, so you can see if the clear saliva is coming out, is normal. But if here the pus or exudation is coming, for me, diagnosis is 100% the inflammation or infection of salivary gland. Yes? So this is important, that where is the opening of this duct. Can be tumor in this region also, and this is the place that we are cutting when is abscess. Mike, one important question. Abscess is located here in the parotid region, but why I cut here? Why I don't cut it here? One is cosmetic region, but the other important. If I cut it like this, I cut all the branches of the facial nerve and paralyzing half of the face. The patient will not appreciate that we saved his life or her life from the infection, but whole life he will be like this and we can sue me. So the place, that's why anatomy, it's important to learn and apply the clinical things that we are cutting here and we remove the exudation, and believe me, it's very bad smell of that one. So the submandibular gland is the second major salivary gland that is located mainly the part of the gland like a hook shape is below the mylohyoid muscle. Please pay attention. The relationship of the mylohyoid muscle. If you remember in mandible, we said that mylohyoid line under and posterior is the submandibular fovea. Above the mylohyoid line and anteriorly is the sublingual fovea. So that's why you can recognize that this mylohyoid muscle that is attaching to the mylohyoid line, it's dividing the submandibular region from the sublingual region, and that's why I'm telling you. But the submandibular gland, it has a hook shape which is turning above the posterior margin of the mylohyoid muscle, and it's going to the sublingual region. And from this sublingual region is coming the duct, which is passing toward the midline of the body here, which is called sublingual caruncle, or sometimes sublingual papilla. And here is the orifice of the opening of the submandibular duct, which is called Wharton's duct as well here. And this is another importance for you, especially dentistry or general medicine, that where is opening of the submandibular. When you are touching or pressing here, so you have to look at it in front of the lower incisor, near to the two sides of the frenulum of the tongue, and if there is an infection coming or pus is coming from the duct or the clear saliva. So this is very extremely important for the recognition of this one. And here's a very nice picture that how it's showing. This is the mylohyoid muscle. And here is this anterior process, sometimes it's called it anterior process, of this submandibular gland that is turning behind or above the posterior margin of the mylohyoid and is going up there and is sending the submandibular duct to the oral cavity proper. And this is the relationship of the duct with the very important nerve which is coming from the infratemporal fossa to the pterygomandibular space, and it's crossing and undergo the submandibular duct. Be careful, lingual nerve is crossing and they go under the submandibular duct from the lateral to the medial side, and it goes to the, according to its name, to the tongue, lingual nerve. Then we are going to discuss that is supplying the sensitive innervation of the anterior two-thirds of the tongue. This is the important for surgery, that the lingual nerve is going under and crossing the submandibular duct, that once more you can see here. And as I told you that the submandibular duct, since is not a bigger than parotid gland, but is producing 65 to 70% of the saliva, comparing to the 20% that the parotid duct has. And here is the submandibular abscess for general medicine and especially dentistry. If you have an abscess in submandibular region, the inferior margin of the mandible is approximately here. Yes, but I never cut the incision of the abscess at the inferior margin of the mandible. Do you know why? This is the beautiful of the anatomy. Yes, he has an abscess. I don't cut it exactly here. I go 2 finger or 2 centimeter below the inferior margin of the mandible, and here I cut. Why? 3 reasons. Tell me one. Because of?
The nerve.
Which nerve?
Mental.
No, mental is here. Mental is above. But another nerve. Again. Marginal mandibular nerve. Branch of the facial nerve. If I cut it here, so I reach to the abscess. I remove the pus, but patient for whole life will be like this. Yes? So this is the important that the angle of the mouse then is coming down. Second, here it's the place that the facial artery and facial vein is going up there and over masseter, anterior margin of the masseter, they go to the face. So there is a risk of bleeding. And third reason is the cosmetic region. So here, cutting is better. The scar is better than here, according to the static view. Sublingual gland, vice versa of the submandibular gland, is located above the mylohyoid muscle and mylohyoid line, and is the smallest of this gland. This sublingual gland, it has two kinds of the duct, which is in this picture, you can see it better. There are the minor ducts, there are several, and they are opening to the submandibular fold or plica submandibularis. And there is one major duct of the sublingual gland, which is connected together or separately. They open to the caruncula sublingualis or sublingual caruncle. So two kinds of the duct you have. So it's the minor sublingual duct, which is open to the sublingual fold, and the major one, which is divided, which is open to the sublingual papilla or caruncle, beside the base of the frenulum here of the tongue in the midline. So this is the major, and here in the fold, they are open to the opening the minor salivary, the sublingual duct. The production of the saliva is 5%, so parotid 20%, approximately 65 or 70%. The parotid, the submandibular duct, 5% is the saliva. The examination always must be bimanual, one from the oral cavity, one is from the outside, to touch the gland or the lymph nodes. You can find it in this area, the stones, the salivary stones, that much big also can be, or small. Here and here it's the stone, biggest stone that is removed. Here can be a target of the tumors, the pleomorphic adenum, and the final, it's the minor salivary gland that they don't have capsule, and they are classified according to the place or location. We have 5 groups. In the lips, labial group. In the cheeks, buccal group. In the behind the third lower molar is the molar or retromolar group. And they are open to the oral vestibule and the palatine that we already discussed, palatine in the hard and mainly soft palate. And in the lingual part, they are open to the oral cavity. Those are the 5 groups of the minor salivary gland. Among them, the tongue or lingual one is very important. The largest one is the apex of the tongue is located, which is producing the mixed seromucous or seromucinous gland. And in the dorsum of the tongue, near to the circumvallate papilla, next week we are going to discuss, is the another gland which is called von Ebner gland. And this is the innervation that we said it just quickly. The parotid gland, the parasympathetic innervation via glossopharyngeal nerve, thanks to the branch of glossopharyngeal nerve, which is the lesser petrosal nerve. It's going and it's supplying going to the otic ganglion, which is a parasympathetic ganglion, and via auriculotemporal nerve is innervating the parotid gland. And here is the blood supply. Submandibular gland, the origin parasympathetic nerve is facial nerve via chorda tympani, which is connected to the submandibular ganglion, and via the lingual nerve, it's innervating the submandibular and sublingual gland. So sublingual and submandibular gland, in this case, we have the same procedure, the facial nerve, preganglionic parasympathetic via chorda tympani from the superior salivatory nucleus, and it's going to the submandibular ganglion and via the lingual nerve to these glands. The small salivary gland or minor salivary gland, it's innervated by facial nerve, one submandibular ganglion, and for palate or palatine gland, it's via the greater petrosal nerve that we said it, via the Vidian nerve or the nerves of the pterygoid canal, greater and deep petrosal nerve, greater parasympathetic, deep sympathetic, via the pterygopalatine ganglion, it's innervating the lesser petrosal, lesser palatine and greater palatine nerve. And this is the location of this parasympathetic ganglion, pterygopalatine ganglion, otic ganglion in the infratemporal fossa, pterygopalatine ganglion in the pterygopalatine fossa, submandibular ganglion in the submandibular region, that they are responsible for the secreto-motor innervation of the glands. Thank you for your attention. Here we said that who knows anatomy, he is on the horse. So thank you for your attention. Yes.